Welcome everyone to this webinar. This week we are going to talk about international patient safety goals and how to implement the international patient safety goals, in short called IPSG, in your practice. Now, most of you might know there are 6 international patient safety goals, but the question is, why only 6? The reason is WHO and JCA and many other organizations, based on the research, have found out that if you focus on these 6 goals, you would actually tackle most of the patient safety problems in your hospital. This is a typical example of the Pareto principle, otherwise known as the 80-20 rule. So here is 20% of the problems, and if you solve 20% of your problems, then you would have found solution to 80% of your patients. So that's the reason there are 6 IPSG goals, and these are: goal number 1 is identifying patients correctly, 2 is improving effective communication, 3 is improving the safety of high alert medication, goal number 4 is ensuring correct site, correct procedure, correct patient surgery. Goal number 5 is reducing the risk of healthcare associated infection, and 6, reducing the risk resulting from falls. So we'll go through one by one and see how we can implement them in our practice. Now first let us look at the goal number 1, which is identifying the patients properly. Now, how do you implement it? First, every hospital should have a patient identification policy. Based on this policy, the healthcare workers should check and verify the patient identity. Next, the patients should be educated and encouraged to participate in the patient identification. Very important. Unless the patient know the importance that patient identifying themselves is important, they may actually get irritated when you go and ask for the name and hospital number every time. So explain the rationale to them and also involve the family in this process. So all this helps to reduce the patient identification errors. The next is generating a unique hospital ID. Every patient who comes to the hospital should have a unique patient ID, otherwise known as the unique hospital ID. And this should result in every inpatient having a wristband which has got these details. It should have the patient name, the hospital number. If your policy is to include date of birth, it can include that, and also a barcode if you're using barcode identification. So this is typically advised that it should be printed on the wristband. Most of the time in most hospitals we find that it is handwritten, and as you know, if you start writing in hand, then transcription errors will creep in. So to avoid this, it is better to print these in the wristband, just as we print patient labels. These wristbands can be printed also. Now, what will you check? There is at least 2 identifiers, as I told you, the name and the UHID. You could, as a third or an alternate, use the date of birth of the patient. Most Western countries use date of birth. Now, you should identify all patients and train the healthcare workers that whatever they do, when they approach the patient, they should identify at least 2 of them. It's very important that training is there. And avoid being in a culture to avoid referring to patients by the room number or bed number or the diagnosis or procedure name. This cholecystectomy patient, this patient with hernia. It's still we follow this. So we should train all the healthcare workers to name the patient by the name. It's very, very important, and it's an important culture to develop. Now, what will you check? This or when to check, sorry, will in all patient interactions. This may include medication administration and many other things. At admission, very important, at the initial assessment, medication administration, all nursing procedures, Interventions is very important. When you're doing some small procedure in the ward or even a surgery, the patient identification should be there. And finally, even when giving the discharge summary, make sure the summary goes to the right patient. So these are all when to check. Now, there are certain special circumstances you have to be extra careful. One is patient with the same name. Now, you should have a protocol if in the OP or in the inpatient ward there are two patients with the same name, the chances of mistakes happening is very high. Therefore, you should have a protocol for that. Unconscious patient with no family members. Many times in trauma, patients are brought without any identification. So, what is your protocol when dealing with that? Unknown patients, again, same thing. Comatose patients in the medical ward. Newborn, very important. The worst thing that can happen is the wrong baby being taken to the wrong mother. So very important to have the protocol of having a footprint of the baby's foot, and also putting the tag on the mother and baby as soon as the baby is born. Now here is an example of protocol we have in our hospital in the outpatient department. You can see this has actually happened in my own OP. This was the two patients who had the same name, and when the slip comes to me, the OP secretary puts the stamp on both these patients. So wherever they go, either to the lab or everything on that particular day, this alert is there. So this is one of the protocols you can follow. Now we go to the second international patient safety goal, which is improving effective communication. As we have already discussed, communication is the major cause for errors in the hospital. Number one. So it's very important to focus on this goal number 2. So effective communication, I'm going to focus today on following phone etiquette, using the readback technique, and using standardized communication tools. We have actually discussed this in the past webinars, so I'll be just highlighting them. So phone etiquette is very important. It is the way you carry yourself while communicating with other healthcare workers over the phone. So it uses you should use the right choice of words. You need to be polite. You have to use the right tone, and you have to most importantly give a chance for the other person to speak. Very important. Okay. So phone etiquette, you have to train all the people who use the phone, and repeat back and read back is very important when orders are given and received over the phone. So what does it include? It is listening actively, when somebody is giving the order, and then repeating it back. So verbally, when you repeat back, when the doctor says give this patient 13 or 14 units of insulin or 15 units of insulin, let's say, you say 15 units of insulin, this can be misunderstood as 50 also. So in the teen numbers, you should never use 15. You should always say 15 or 50. Okay. So you repeat it back to get the confirmation, and then you write it down. So after writing it down, then you have to read it back. So that is what is known as read back. So the read back policy read back procedure has two elements. One is repeat back to verbally confirm, and then write it down and read it back. So this is the process of read back. Now for communicating with the patients and the family, several communication tools are available, and these are all from the West. So therefore in SkillsForMed, we have actually developed a communication tool for communicating with the patients and family, and this is known as GREET, G-R-E-E-T. So this is, we have applied even for a trademark for this. So G stands for greet the patient with say vanakkam or good morning or good afternoon whenever you encounter a patient. Next is relate. So you first relate yourself. You tell, I am Dr. Pari, I am a surgeon, I have come to see you. Similarly, any nurse will say, I am maybe so and so name, I am the staff nurse or whatever, superintendent nurse or whatever. You tell the name and designation and relate yourself to the patient first. Then you talk to the relatives and also relate to them. So that is relating. E is inquiring. So it's an Indian culture. Whoever comes, now we are asking, how are you? That's the first thing we'll ask for any guest. So you should also, the moment you introduce yourself, the next question should be, how are you? How are you feeling today? Especially for patients, you need to inquire them for the well-being and also provide the privacy. Then the next E stands for explain. So this is whatever procedure you do, you should explain the procedure before. Say this is what I've come to do, and then during the procedure give a running commentary of what you're doing. So that is communicating during the procedure to put the patient at ease. And finally, after the procedure, you've got to communicate them about the safety measures. And finally, T stands for thank you. So after doing the procedure, you thank the patient. And finally, before leaving the room, you ask this very important question. Is there anything else I have to do for you? This will prevent the patient from ringing the call bell as soon as you walk out of the room. So very important to ask the question and make sure all the safety measures are followed. So this is the GREET acronym or GREET tool for communicating with the patients and family. Yeah, this is for healthcare workers, other healthcare workers. We use the IS bar: identify, situation, background, assessment, and recommendation. So this is the IS bar tool. All of us are familiar with this. So this is what is used to communicate with the healthcare workers. So that brings us to the third IPSG goal: improve the medications. So medication errors are a leading cause of injury all over the world, and they occur in different stages of the medication administration, right from prescribing to administration and monitoring. So let us look how we can implement the patient safety goal 3, medication safety. So always check medications before administration and document it. So how do we do this? We use the 6 rights of medication administration: right drug, right dose, right time, right route, right patient. And what is the 6th is the after administration you will immediately document it. So these 6 rights are very, very important to reduce medication errors. So when will you check these 6 rights? Just like hand hygiene has got 6 steps, medication administration also has got 6 rights. Now hand hygiene also has got 5 movements, isn't it? You got to do the 6 steps of the hand hygiene in those 5 movements. Similarly, in medication administration, there are 3 movements of medication administration, and these are known as the triple check. The 3 movements of medication and administration is known as the triple check. So when all we should check, you should check after taking the drugs from the storage. Second check is before preparing the medications, and the third check is before administering to the patient. So the 6 rights has to be done at these 3 moments. Very, very important. So 6 rights and triple check are very important to reduce medication safety. The other important thing is alerting or implementing the high alert medication program. Now what is this? So you need to make a list of high alert medications. I'll tell you what are high alert medications in shortly. You can use the International Safety Medication Practice website as a guide. For your hospital, you need to standardize how these high alert medications are handled in the pharmacy, how prescriptions are written, how will the nurses use, and train all users on the high alert medication program. Finally, you need to audit and improve this practice. So some examples are insulin, anticoagulants, opiates and sedatives, potassium, and chemotherapeutic drugs. So in short, any drug which has got a very narrow therapeutic window, that is, if you give small dose also it is a problem, if you give slightly larger dose also it's a problem. Or drug which, if it extravasates or it may cause very serious problem like chemotherapeutic drugs. So these are all included in the high alert medication, and you should have a policy for that. Now here is an example of lookalike drug. You can see how the package is so similar. So these are lookalike drugs. And here are some examples of sound-alike drugs where you can see the pronunciation of Levolin, Levoret, Lenoxin, Zonoxin, Zysel, Zysal are all so close that people can mistake one for the other. So these high alert medication, lookalike and sound-alike medication should be stored as far away as possible and should be stored securely so that people just can't grab them and dispense it. So this is what I told about the Institute for Safe Medication Practice. This is the ISMP list of high alert medication. So you can Google it and find this out. There's a huge list. So take which is alert, which is the relevant to your hospital and use that as your high alert medication list. So the other thing which you can do to reduce medication errors is double checking. Now one thing I wanted to point out here is there are two ways you can actually double check. So one is shared double checking and other is independent double checking. So what is the difference? So shared or 2% double checking is what we usually do. So there are two people. So one person reads out the all the details and other person checks. So this is the 2% checking. Now they found when there are 2% checking, there is always problem of accountability. One person thinks, oh, the other person will take care of this, and therefore they relax. So therefore medication errors even happen in shared 2% checking. So they said, let us do independent, double independent checking. That is, I will go and check all the details and then come off. After some time, the second nurse who is actually giving it will also do that, and then they will check whether both are the same. This is known as double independent checking. So both have its pros and cons. So actually 2% checking is very useful when you are a busy unit. So you can't actually find time for doing double independent checking. Whereas centers which have low volumes can follow double independent checking. So there are also best practices for using drug chart. So there's a whole talk webinar itself. I think the next webinar is going to be about it. So using best practices for using drug chart is another way by which you can reduce medication errors. Now that brings us to the fourth IPSG goal, that is ensuring correct site, correct procedure, correct patient surgery. So as a surgeon, this is something I dread about. If in my career there is one case of wrong patient or wrong site surgery, my career is finished. So it's very important, and the hospital gets a very bad name. So it's very, very important to safeguard against this. And how do you do that? It is make sure that the surgical site or site is marked correctly, and use the surgical safety checklist before and during and after the surgery. So we'll quickly look at this. Certain best practices for surgical site marking. I will just go through the do's and don'ts. So first the do's, what you should do, verify with the patient and relative. Each of these things, if you see, very, very important to involve the patient. Patient engagement is very important. They know which side the problem is, right? So before marking, involve the patient and the relative. Ask the patient to point out which side and where the surgery is going to take place. That has been explained by the surgeon. Then you check your notes, you check your imaging reports, confirm it, and then mark with a permanent marker. And this mark should be placed very close to the incision site. I'll tell you why. It should be placed, that is why it is known as a site marking. And then you have to document your name and sign in the pre-operative checklist that you are the one who have done it, to take the responsibility. Now what you should not do. So mark the non-procedure site. You don't put a tick for the site and then put a cross on the non-procedure site. That will lead to confusion. And never use X to mark the site. Always have either an arrow to mark it. This should be an uniform policy, because X, people can confuse. And never use a whiteboard marker or a erasable marker. And put it in, and I said no, put it close to the site of surgery, because in the theater, at the surgical safety checklist, when they do the timeout, the marking should be visible. So that's the reason we say mark it close to the incision site. So don't place it, and for a hernia, usually they'll put a mark at the dorsum of the foot. So that should not be done. Now suppose marking cannot done, for newborn babies or ENT procedures or oral procedures, you may not be able to actually do a site marking. So, or sometimes patient may be so finicky, they say, no, I don't want you to put a permanent marker on my body. So then you have to put again a wristband where all the details, the patient name, the name of the procedure, the site, and the site should be written on the wristband for it to be checked in the timeout. Okay, so the patient name, UHID, the site and organ to be or operated upon should be there. Okay, so the surgical safety checklist again is a topic by itself. So I will only tell you that it has to be done at three important checkpoints. One is before the induction of anesthesia, which is done by the nurse and the anesthetist, and this is known as the sign in. The second is done by the operating surgeon, scrub nurse, anesthetist, and the circulating nurse. This should be done before the knife touches the patient, before the skin incision, and this is known as the timeout. And finally, the third is called the sign out, and this happens before the patient leaving the theater, where you check the specimens and things like that. Okay, so all these help to prevent wrong site, wrong patient, wrong procedure problems. So now we are coming to the fifth international patient safety goal, and this is reducing the risk of healthcare associated infection. So how do we do this? This is by using care bundles. So care bundles are evidence-based interventions for all the healthcare associated infections like CORTI, CLABSI, SSI and ventilator associated events. So let's quickly look at these bundles. So the CORTI bundles really helps to minimize the healthcare associated infection. So the nurses and doctors should ask themselves, can this catheter be inserted? Have I used the right technique for insertion? Has the catheter been maintained by the that is known as the maintenance group properly? And finally, when should the catheter be removed? So these are all the questions in the bundle care in CORTI. So next we'll get into CLABSI. So for CLABSI, there is a very important lesson learned from this project. This is known as the Michigan Keystone ICU project, where they just used 5 factors and found that the CLABSI rate can be reduced to almost 0. Very simple 5 procedures. Okay, what are these steps? One is clean the skin with chlorhexidine before putting the central line. The second is sterile draping should be done not by a central hole but from head to toe as if you are doing a surgery. That is the second parameter. The third is perform hand hygiene. That is as if you are doing an operating procedure up to the elbow, and then wear full gown and sterile gown. Don't just wear gloves. Don't just use chlorhexidine scrub and then hand rub and then wear gloves. No. You need to do a proper surgical scrub and wear surgical gown and sterile gloves. That is 3. 4 is avoiding the femoral site. It has been shown femoral site leads to more incidence of catheter related bloodstream infections. Therefore, you should avoid femoral site. And finally, every day you ask yourself, can this central catheter be removed? So avoiding unnecessary lines. So they, just by using these 5 parameters, they were able to bring down the CLABSI rate not only in one hospital, in the whole Michigan area, in about 18 or 21 different hospitals, and now they have expanded it to the whole country. So this is how you reduce the CLABSI rate to 0. So next is the SSI care bundle. Here it is performed at 3 different phases. Preoperative care, you need to have a preoperative checklist. Intraoperative care is again, the surgical safety checklist, and postoperative care you should have a checklist after the patient goes to the ward immediately what needs to be done. So the WAP or the VAE checklist is the last one in the reducing HI infection. Here oral care with chlorhexidine, stress ulcer prophylaxis using antacids, daily sedation assessment and spontaneous breathing trials to make sure they come out of the ventilator, DVT prophylaxis, and always keep the head end of the bed elevated. So these are the bundle checklists you use for the WAP or the VAE. Okay, so that brings us to the 6th goal of the IPSG. So this is reducing the risk of patient harm resulting from falls. So innumerable number of patients get this problem when they're admitted to the hospital, and it's totally preventable. So now How do you implement this? You need to perform fall risk assessment for every patient who gets admitted to the hospital and use fall prevention strategies. Now, how do you assess? You have to use one of the validated fall risk assessment tools, for example, Moore's fall risk scale or stratified, whichever that is used in your hospital. And there are certain patient related prevention strategies and organization or healthcare related prevention strategies. Patient related is orienting the patient to the room and the hospital is very important, so that they know where the bathroom is, they know where the furniture is, so they don't fall because of the ignorance. And make sure that patient's aids like spectacles and hearing aids are in working condition and placed near the patient. And make sure the patient is either wearing well-fitting slippers or not wearing it. Very important in our country. Most of us do not wear slippers in the patient room. The patients don't wear. So if they're wearing a footwear, make sure it is correctly fitting and it doesn't lead to a fall. There's quite a lot you have to cover in healthcare related strategies to prevent fall. So you have to first identify who are at risk, report to your supervisor. Appropriate aids, I already told you, walking aids, toilet handrail should be installed. Make sure that bedside table and belongings is placed as close to the patient when you leave the patient, so that they don't stretch and take it out and fall. Okay, they should be within the hand's reach. Nurse call button should also be within the patient's hand reach. Always raise the side railings up when you leave the patient alone, and the bed should be, if it is a bed which goes up and down, it should be at the lowest height. And whenever the patient is transported, they should have the straps put on while transporting them. And in a wet floor, put these warning signs. So many of the staff fall down, because they're running about and they walk without noticing. So very important to put these warning signs. So these are the prevention strategies for fall. So we have come to the end of this webinar, and to summarize the 6 international patient safety goals. Goal 1 is correctly identifying the patient. So always use 2 identifiers. Staff training, very, very important that everybody uses these 2 identifiers, involve the patient and family. Goal 2 is effective communication. I talked about phone etiquette, read back technique, and communication using communication tools like ISBAR and GREET. Goal number 3 is improving the safety of high alert medication. Triple checking, that is the 5 rights of medication at the 3 moments of medication administration. Taking out of storage, while preparing, and before administration. Documenting it in the drug chart, and having a high alert medication policy. Now the 4th goal is ensuring safe surgery. We talked about the importance of surgical site marking, and then pre-operative checklist and the surgical safety checklist. The 5th goal is reducing HAI, and this is by using the bundle care. All the HAI bundles should be used whenever appropriate. And the 6th is preventing the falls, for which you use the fall risk assessment and fall prevention strategies. So thank you so much, ladies and gentlemen, for your patient hearing.